steroids are released by the adrenal cortex, right? We got three varieties of steroids. We have the mineralocorticoids, we have the glucocorticoids, and we have the androgens or estrogens and progesterones, right? So there are actually 17 different steps to make steroids, and they kind of branch off at certain points. And of course, we don't have to know all 17 steps, but basically to know what comes out of them, right? You have aldosterone. It's the only mineralocorticoid, so it deals with salt, right? We have glucocorticoids. It's gluco because it deals with sugar, right? And that's your cortisol. And then you have sex hormones. That's your estrogen and testosterone, right? So those are our three different layers of our adrenal cortex, which is, again, the adrenal gland is added to the renals. And we haven't talked about the nougat center yet. The nougat center is not steroids, it's your norepi and epi. And we'll talk about them in this section because I have no other better place to talk about them, right? So we're talking about adrenal gland dysfunction. But mostly we're talking about steroids. And when we talk about steroids, you're mostly talking about cortisol, right? Cortisol is the main player that comes out of the adrenal cortex, besides aldosterone. Aldosterone is going to be coming out in response to two things. One thing is the RAS system, right? Angiotensin 2, or high potassium, right? It's the only hormone that's going to get rid of potassium in the body, so it responds to high potassium. So you can see here, we got the three S's: sugar, salt, and sex. Those are three things that happen when you have too much steroids, right? And in Cushing's is cushioned with steroids, and Addisons, you need to add steroids to fix it, right? And you add steroids to fix it. If you don't, you're going to get an adrenal crisis where you have too little steroids. And Cushing's is adrenal excess is a really like emergent situation, no, but it's Cushing's is an adrenal excess. And there's such thing as Cushing's syndrome and Cushing's disease. And syndrome is due to us giving too many steroids because we can give cortisol to patients, right? We can give exogenous steroids to patients. Or there's a problem where you're producing too much steroids, and when would that happen? Tumor, right? So tumor can cause too little or too much of an endocrine situation. So the adrenal cortex. So again, we got our mineralocorticoids up top. And there's only one mineralocorticoid that deals with minerals, and that's our aldosterone, which deals with sodium and potassium, right? That's the only thing it does, right? And if it's going to reabsorb sodium, water will follow, will restore our preload, and it'll get rid of potassium. So if I have too much aldosterone, right, that's going to cause hyper or hypokalemia. Hypokalemia, very good. And it causes hypernatremia, right? Because sugar, salt, and sex, right? So I got sugar right here. I mean, that S, I guess why that means sugar. I got salt right there, and I got sex right there, right? So I got too much salt, so hypernatremia, and too much sugar, cortisol, right? Cortisol has other functions too, right? We talked about mineralocorticoids briefly, right? Due to elevated PK or angiotensin 2. And again, it's going to restore blood pressure and preload. And then we have our steroids, right? Or sorry, we give exogenous steroids, right? But we have our glucocorticoids. We talked about in diabetes, they get released when you have low sugars. So when you have low sugars, it's going to break down glycogen, break down lipids, and it's the only one that breaks down proteins. And therefore, we get a lot of side effects because of that, right? We get a Cushing's syndrome as a result, right? Especially if we gave the steroids. All right, so we have elevated blood sugars. It's anti-inflammatory. That's an important situation that we want to, that's the reason why the SNS was firing off. When you have an infection, the SNS fires off, and also when you have an infection or inflammation, cortisol gets released. Both are interchangeable and are going to go out there and have anti-inflammatory effects. Because you have inflammatory and you have anti-inflammatory, and in sepsis, you have too much inflammation, and it causes a syndrome of inappropriate, I'm talking about SIDH, it's causing systemic inflammatory response, right? And that can cause a lot of complications, including multi-organ failure, AKI, and ARDS, all kinds of DIC, all these problems. So we need anti-inflammation to cool it down, right? That's what the anti-inflammation is for. And that's what cortisol is doing. And also we have steroids. They are, if you look at gastric physiology, steroids directly stimulate or directly inhibit prostaglandins. They are anti-inflammatory. Prostaglandins are inflammatory, right? So if we inhibit prostaglandins, yeah, the pain might go away, the inflammation might go away, but we are also going to lose the prostaglandins' protective effect on the on the gastrum. So we're going to get peptic ulcers as a side effect. And then we have weak aldosterone function. So every glucocorticoid, I mean, when it's going to mimic mineralocorticoids. So you kind of think of these guys together almost, right? So too much with Cushing's syndrome, where I'm cushioned with steroids, I have too many steroids. I'm going to have all the steroid side effects, but I'm also going to have hypernatremia and hypokalemia. Okay, so that's the idea with glucocorticoids. All the androgens and our estrogens, progesterones, we're not going to worry about them. They're on their own path. They're stimulated by the pituitary and FSH, LH, all kinds of fun stuff over there, luteinizing hormone, etc. So that's the adrenal cortex, right? The cortex is releasing these 3 hormones. There's 17 different steps, and it's doing its thing, right? At least the 2 hormones we're worried about are aldosterone and cortisol, right? And then what else? We have the adrenal medulla, which is our little creamy nougat center, right? That's where epinephrine and norepinephrine get released in response to the SNS, right? SNS will come down here and release norepi and epi so that we sustain a SNS response, right? The SNS also goes to the kidney on the beta-1 receptors and triggers the RAS system, and the RAS system will trigger the adrenal gland to release aldosterone, and then we have the aldosterone function, right? So we're kind of putting everything together that we've been talking about as far as the cardiac system and the renal system, and now we're adding the little endocrine piece, right? And just like the thyroid hormone, it's on its own negative feedback. So if you have a lot of cortisol, that's going to inhibit the release of its tropic or release stimulating hormone, right? So when T3, T4 was high in thyroid disease, it went to the pituitary, and the pituitary says, oh, T3, T4 is high, I'm going to reduce my TSH. So what's the equivalent in the endocrine world, in the cortisol world? ACTH, adrenocortex or adrenocorticotropic stimulating hormone, right? So ACTH is one of our key hormones that we're going to look at to see if we have primary disease, the organs at fault, or secondary disease, not the organs at fault. Like the pituitary tumor is causing too much ACTH to be released, for instance. Okay? Or it could be primary disease, where I have too much cortisol being released, or too much aldosterone being released. So indications and routes of our glucocorticoids. So steroids can be IV, Pheo, inhaled. When you talk about inhaled, you're thinking of more of a COPD asthma patient, right? Where they have an inhaled corticosteroid. But IV steroids you see very common in the ICU, and these guys are getting usually a 5-day course. All right, 9 times out of 10, it's a 5-day course of steroids. When the steroids are actually ordered here, the default is 30 days. And no one gets 30 days. Even in like severe ARDS, where you get a 21-day course, right? No one gets 30 days of steroids, right? You might add on steroids, like they're not doing good. I do another 5 days or 7 days. It might equal 30 days in the end, but by default, no one gets 30 days. It's always 21 days if it's ARDS, or a 5-day course for someone like COPD exacerbation or a pneumonia that's community acquired. Right, so that's the usual standard. So usually we have to catch that and make sure we're not just being machines just giving IV push steroids every day, right? Because we know there can be complications if we give it for more than 21 days. If you give steroids for more than 3 days, your adrenal gland's like, you know what? I see you with that other woman, or I'm gone, bye, right? And your own cells are not gonna produce steroids anymore. So if you get an exogenous action, right, that's going to cause a lack of your own endogenous production of steroids. And therefore, after 3 weeks, and you take away someone's exogenous steroids, you're not getting those steroid injections anymore, then your body's going, whoa, shoot, now there's no steroids. It takes about 7 to 10 days to kind of ramp up production again. So that's a key piece to think about when someone's on steroids at home, like dexamethasone PO at home, or prednisone at home. Those guys have probably been on a course more than 3 weeks. So these guys, when you're doing med reconciliation, you're like, oh shoot, they're on steroids at home. We need to resume steroids in the hospital setting. Otherwise, they're going to have the signs and symptoms of steroid deficiency, which is called adrenal crisis, right? Where the adrenal glands are not producing steroids anymore. Okay, so if you're more than 3 weeks of steroids, you have to taper the amount, right? So you go from 125 to 60 to 40 of methylprednisolone, for instance. If it's less than 3 weeks, it's absolutely not necessary. You'll see it happen all the time. We completed a 5-day course of steroids. What do we do next? And it's like, let's try, instead of 125, let's try 90. It's like, and then tomorrow let's try 40, and then tomorrow let's try 20. And so it's sometimes they might do that if the rescue status is very, very tenuous, and they're we're kind of hoping we're really trying to ease them off high flow oxygen or stuff like that. But for the most part, all you do is cold turkey, straight off. You take it off. That's not going to cause an adrenal crisis. What will cause adrenal crisis is more than 3 weeks of steroids, right? That's when you're on home dexamethasone or home prednisone. Then yes, you need to taper it down, right? Or you need to start steroids and then taper down if you need to. All right, hydrocortisone is the weakest. Is weaker. Is very, very strong. It's weaker than dexamethasone. So the order of how strong steroids are, this order right here, right? So hydrocortisone is weak. It's short acting, but and dexamethasone is extremely long acting. You can see, and is extremely strong. So the other piece with that is you notice the blue activity. The blue activity is its salt retaining activity. If someone has ARDS, do you want to retain salt where water follows? And that's more fluid that's on the system. So that's why they might consider dexamethasone over like hydrocortisone, for instance. Okay, so dexamethasone has no aldosterone-like activity. It's one of those unique ones, right? But everything else you can think of: too much steroids, too much sugar, salt, and sex. Okay, and then the action. What does it do? As you mentioned, it calms the immune system down. It has that autoimmune reaction, autoimmune activity. I said anti-inflammatory activity, sorry. So it's up here and it's stopping the production of prostaglandins. In the lungs, that's great because the lungs are going to bronchoconstrict. So we give the steroids to someone who's like in an asthmatic crisis or someone who's in a histamine excess, right? We're going to give steroids to stop that histamine production and that bronchoconstriction. But what else do they usually do? They're kind of stopping the infiltration of white blood cells and therefore inflammation from happening. They're stopping the antibody production by the B cells. They're stopping T cell activity. So they're really shutting down that inflammatory process we talked about in hematology, right? They're shutting everything down, slowing down maturation. It's time to cool down, guys. That's the idea what corticosteroids are doing. So are they at risk for infections? Yes, because they're doing this. But ironically, they're in the ICU because of an infection that made our body have way too much of an inflammatory response. So we had to give steroids to cut that down. Okay, so prostaglandins, leukotrienes were involved with bronchoconstriction, which is why we give them an asthma. Okay, side effects are all explained by the proteolysis, by the anti-inflammation, and the gastric ulcers are because of the prostaglandins were protective in the GI tract. And diabetes, well, this is a glucocorticoid, right? So we have too much glucose being made. I'm at risk for diabetes or glucotoxicity from too much steroid use. We talked about the sugar, salt, and sex, right? We got too much salt right there. We got too much sugar right there. And we know it has aldosterone-like activity when it's in high amounts. So we're going to get low potassium. So low potassium, high sodium, right? Are two actions of too much steroids. The other thing that happens is we start breaking down glucose or glycogen stores to get the excess glucose. We break down lipids, and you break down the lipids, and then your body's like, you know what, I don't know what to do with these lipids. What do I do with them? I broke them down. I have excess cortisol. Where do you put them? And they say, hey, I put them away. And your body, where'd you put them? Where? Where is it at? I put it in your pack. I'll give you a little buffalo hump. You'll thank me later, right? So you get a dorsal cervical fat pad. You get a buffalo hump. Is a result of lipid breakdown and redistribution of fats. And then they say, I put it elsewhere. Where else you put it? Tell me. Where'd you put it? I put it on your face. I made your face more round. All right, so you get moon facies. And it's like, why do you call them moon facies? That doesn't sound pleasant. So you get this moon face and buffalo hump, right? And also they can't fight off infections, so they're at risk for acne. So you get acne and a moon face. That's not fun. And then we broke down lipids, and we start breaking down lipids in the extremities more than the belly. And the lipids that does get broken down in the extremities gets deposited on the belly. So you get the central adiposity, the central obesity. that occurs with someone that's on steroids. Okay, and then it says lipids and glycogen, but what about steroids, proteins, protein breakdown? So we mentioned that the most common protein that's in the body is what? Found the most amount of the body is muscles made of actin and myosin and such. And yes, you'll get weakness and fatigue with steroid use, but what else? That's with like corticosteroids. With like androgens, you'll get more muscle buildup with testosterone and such. But with excess steroids, you're going to start breaking down the most prevalent protein in the body, and that is collagen, right? So collagen makes up the majority of our bones, so they get bone fractures, right? They get osteoporosis and fractures, right? And then we get a breakdown of the collagen that's in our skin. So we get stretch marks, right? So we get striae, and we get breakdown. Also, this collagen in our skin, we get paper thin skin, and also we break down the collagen surrounding our vasculature. So we get easy bruising, right? So you get easy bruising as well. So is it there? Easy bruising. All right, so you get bruising as well. It's not like it's like interrupting the platelet function or something like that. It's because the vessels and the capillaries are literally friable. They're literally breaking apart like paper thin. All right, so adrenal insufficiency. This was someone who did not get their steroids or were on steroid therapy for more than 21 days, and someone did not taper or someone did not replace the steroids, for instance, or they did not taper it if they're on steroids in a hospital setting for more than 21 days. Right, so if you have adrenal insufficiency, you don't have sugar, salt, and sex. That means you have low salt, and you have low sugar, and you have low sex. No, you can't really measure that, right? But we're going to have low aldosterone function, therefore hyperkalemia, because aldostorone's only job is to get rid of potassium, or not only job, but it's the only hormone that gets rid of potassium in exchange for sodium, right? Cortisol will be released in adrenal insufficiency, overall adrenal dysfunction, and that can happen like post-TB, for instance, right? TB can invade the adrenal glands, or a tumor can invade the adrenal glands, and my adrenal glands don't work anymore, and therefore I have less function of my adrenal cortex. And the decreased testosterone, and they get thin, fatigued, they get this unique hyperpigmentation. All right, so here with therapy, with adding steroids to this person, they were able to get to a normal skin tone. Okay, so primary disease is called Addison's disease. That's where you need to add steroids to fix it. And these patients are, hyperkalemic, and hyponatremic, and it can lead to an Addison's crisis, and that's where they go into a shock state. So it's, you can have Addison's disease and live with it, and then you have to take steroids, obviously, to recuperate and recover. But if they don't take their steroids, then they can go into an Addisonian crisis. Who else can go into an Addisonian crisis? Again, if steroids weren't tapered, can make it a problem as well. Okay, and so that's a primary dysfunction. The organ itself is not working, not doing its thing. And then there's a problem with the pituitary. The pituitary is not releasing ACTH. The adrenal glands work just fine. It's just there's no ACTH being released from the pituitary gland. And what caused that? Tumor, right? That's a reason, right? And stopping steroids can also be a reason, because you have to ramp up production again to get everything back to normal where it was before you had chronic glucocorticoid use, right? So there's AM cortisols that can be done, random cortisols that can be ordered to figure out what's going on. Is it a primary reason or a secondary reason? Usually you're involving endocrine at this point when you're considering an Addisonian crisis or adrenal crisis, right? There's AM cortisol, it's highest in the morning, and if it's low, that means there's a problem. You're not producing the cortisol you should. But if they've gotten steroids at any point, it's not very accurate. So that's why you want endocrine involved, and they're going to follow up in the outpatient setting to see if they have there's a situation happening. There is an adrenal crisis, in fact, right? I should say adrenal insufficiency, because a crisis means they're in the ICU with hypotension, and we're giving high-dose steroids to turn them around, right? They're in the ICU with a vasodilatory shock because steroids make it so that adrenal receptor or adrenergic receptors work, right? So if you ever notice, if you give a patient like on 3 pressors and then you give a dose of steroids, right, it's going to last about 4 hours until the next dose of steroids. And they'll get hypotensive, and you give another IV push of steroids, and whoa, look at that, the blood pressure is better. It's because it kind of like primes the receptors so they can work good. So adrenal crisis is that Which one is that? Cushing's or Addisons? Is adrenal crisis? Who's at risk? That's the Addison's person. That's the one you need to add steroids for. These patients are deficient in steroids, right? And they have a shock state, a vasodilatory state because they have lack of aldosterone, yes, but they also have lack of cortisol, which again primed our receptors for the SNS to act, right? They don't have sugar, salt, and sex. They are decreased in it. They have decreased sugar. They're very, very hypoglycemic. They're very hyperkalemic. And that's kind of you just look at the labs, you look at, oh shoot, look at that. They've got high sugar, they got low sodium and high potassium. That is an adrenal crisis until proven otherwise. And they got low blood pressure, well shoot. That is definitely someone that is in a crisis situation, but we can suspect that it might be a adrenal situation, right? Adrenal dysfunction. And we can look at the med history and see, oh shoot, they were on steroids at home. They're on dexamethasone at home, right? Because like really end-stage COPD patients, end-stage asthmatic patients will be on steroids at home, right? So we have to take a note to that and continue steroids in the hospital setting, okay? And then when they have adrenal insufficiency, we want to give steroids first, right? So, I mean, because you might think of someone's like in this comatose state, it might be hypothyroid. That might be the situation. But usually that we want to make sure we are, you don't want to give thyroid hormone first basically in that situation because that's going to cause a worsening outcomes. All right, so adrenal hyperfunction. So too much of just one specific area of the adrenal gland. If I just have too much aldosterone, that's technically called Conn syndrome. There's Cushing's disease, which is the whole thing. I have too much mineralocorticoids and glucocorticoids, too much sugar, salt, and sex. And then there's Conn syndrome, where it's just the outer layer is increased in amount. So it's just they're just going to have hypo or hypernatremia.
They'll have hypernatremia.
Yeah, so in Conn syndrome, where they have too much aldosterone, right, they're going to have too much sodium reabsorption, right? So that's the idea with Conn syndrome. Cushing's syndrome, yeah, they're going to be hypertensive. They're going to have too much sodium in water as well because Cushing's kind of encapsulates Conn's as well, right? And again, these are caused by tumors. That's the most common reason. Either be a tumor of the pituitary that's causing the Cushing's or a tumor of the middle layer of the adrenal gland, or adrenal cortex, is causing too much steroids being produced, or it's just a tumor of the outer layer, just the outer layer, and that's what's causing the excess release. Okay, so we can do tests, look at an ACTH test, you can do a TSH test, and there's more fancy tests we can do on the outpatient side where you can look at aldosterone levels and renin levels and such to see if there's something else going on. But that's kind of beyond this scope. That's more outpatient stuff. All right, so Cushing's disease, there's technically, you can look at it as an ACTH reason, too much ACTH being released from the pituitary, or is it a tumor on the adrenal cortex, like I mentioned, right? And so the idea is Cushing's disease is because of a disease process, a tumor, whereas Cushing's syndrome is because of a syndrome of symptoms because I gave them too many steroids exogenously. Okay, so that's the idea, and there's a lot more discrepancy where we look to see if it's, is it dependent on is it pituitary or not pituitary, and that's kind of beyond what we're talking about now. All right, the last thing to talk about is a tumor of the last layer of our last part of our adrenal gland, and that is our nougat center, right? So we have the adrenal gland, we talk about all the cortex stuff, all that stuff on the outside. What about the middle, right? That middle part there releases what? Norepi and epi, right? So the norepi and epi is going to be in profound amount, and that adrenal medulla is secreting it, what's the word? In a labile fashion. It's not like all the time. It's like, oh, you know what? It's time to release norepi and epi. Bam, it gets released. It might be due to stressors. It's kind of hard to predict when the norepi and epi is going to get released, but they are going to present with very, very high blood pressure, like the 220s, 240s. And then it's like, then you start cardine on them, nicardipine, you get the blood pressure control, and the blood pressure all of a sudden is like 110. It's like, well, cardine's at 2.5. That's the lowest dose. What's going on? So it's very hard to predict what's going on. So yes, calcium blockers can be given for these patients, but usually we give something to block those alpha receptors, right? Because the alpha receptors are what are causing the vasoconstriction. And norepi binds those alpha receptors, just like, if we give like neosynephrine or phenylephrine. It binds those alpha receptors directly and raises their blood pressure. And that's what's happening here, right? So we don't give beta blockers because beta blockers might just block the heart. We want to block the whole thing, right? So we're going to be blocking with phentolamine. Phentolamine is going to inhibit just the receptors, just the alpha receptors, right? So phentolamine is also given for another reason. Do you know the reason for that is? Phentolamine is also given for vasopressor infiltration. So if you have infiltration of vasopressors in your extremity doesn't, vasoconstrict and die off, we give phentolamine as little injections in a little, clock-like manner, and that's going to cause a dissociation of the medication, the vasopressor, from the alpha receptors and allow hopefully our vasculature to return. All right, so it's always what you ask for, regitine or phentolamine, when someone has a vasopressor infiltration. Okay, but again, pheochromocytomas are extremely rare. I've probably seen like 2 in the last 15 years, so they are extremely rare, and it has that labile nature to it. It's all of a sudden, bam, the pressure is super high, and sometimes it's just super high because someone's just super anxious. And you have to well, are you anxious or do you have a tumor? And then of course you probably get a CT and you'll find out, oh shoot, that's not anxiety, that's a tumor, right? Another agent is phenoxybenzamine, but usually phentolamine is what we use. Okay, 90% of the time you have this tumor that's growing and growing and growing, and it can cause increased catecholamine, norepi release. That's going to cause a profound hypertension. All right, lastly, our other endocrine stuff that didn't fit in the other things. We talked about calcium again with CKD, but we're looking at we're not worried about gonads, we're not worried about lactation, right? And oxytocin, we're not worried about pregnancy, but we're not worried about pediatrics with GRH, growth hormone we talked about, right? But we've talked about thyroid hormone, right? We've talked about our adrenal glands, and we've talked about not so much dopamine, but we've talked about what else? We talked about our vasopressin, right, with ADH problems. So now we're talking about what happens if the whole thing is gone. What if there's a tumor of the whole thing and nothing gets produced? Well, that means I get all these symptoms, right, are going to be low. What if I have a tumor that's making too much production? Well, that means all these things are going to be too much. So I'm going to have a hyperthyroidism crisis. I'm going to have SIADH. I'm going to have Cushing's syndrome. I'm going to have Pheo, not really, but because it's really a pituitary problem we're looking at. All right, and when you have too much stuff, we just yoink it out. We do a little orchiectomy. We do a little, not a vasectomy, but an orchiectomy. We're going to take out the little gonads here, and we're going to then have PanHypoPit, or PanHypoPituitarism, where we have no pituitary function. And you have to replace it all. You have to replace growth hormone. You have to replace, if they're young, you have to replace thyroid hormone. You have to replace ADH with DDAPP. You have to replace steroids. So that's the idea here. So that's why we talk about this last, because we're gonna add on everything we've been talking about so far. All right, so you have pituitary mass. It can cause too much or too little action, right? So we have too much, too little action of the pituitary. And what does the pituitary do? It releases what kind of hormones? Releases stimulating hormones, right? Releasing hormones technically are coming from the hypothalamus, but the stimulating hormones come from the pituitary, and it's because I have too much ACTH, too much adrenocorticotropic hormone. I have too much TSH, right? I have too much ADH. Does ADH come from the posterior pituitary? No, it comes from the anterior pituitary. And it's sometimes involved, but definitely thyroid is involved, definitely steroids are involved, and growth hormone, especially at a young age or an adult, can cause dysfunction, right? At a young age, of too much growth hormone, they're going to be super tall, right? At an older age, you're going to have growth of the bones. They get this acromegaly. They get this disfiguring effect on their bones, which is not reversible. Okay, so 1 in 6 people have a pituitary tumor, so that means 1, 2, 3, 4, 5, 6. One of you has a pituitary tumor, right? But is it common? No, it's very, very rare for it to happen. It's not as rare as Pheos, but they are as pheochromocytomas. But they are we do see them about 2 or 3 per year. We'll see these patients come in. Okay, and these secreting tumors, right, are going to be producing way too much of these hormones, so we have to ultimately they can't give like antagonists to these hormones. You have to just go ahead and take it out. And how do you take it out? You just go in there and don't do a lobotomy. You're going to go in through the nose, and you're going to take out the pituitary gland. And when you take out the pituitary gland, now you have hypofunction. Now you have too little thyroid hormone, too little ACTH or corticosteroids, right? And too little ADH kind of gets affected as well. So we have to replace everything if we take it out, right? Back in the day, they used to do lobotomies. Back in the day, as in like the 60s and 70s. That's as far back as, that wasn't that far back. But back in mummy times, they would go back and they didn't think the brain was important. They just thought it was when someone died, they're like, oh my gosh, what is all this junk? Let's just throw this away in the trash. They threw away the brain. They thought that the thoughts and the hearts and the emotions all came from the heart. So the heart, yeah, they saved the heart, but the brain just threw the trash next to the patient, next to the deceased. Okay, so we have all of these symptoms that are going to be like hyper or hypothyroid, whether it's too much or too little of the pituitary gland, right? It's hard to predict, and of course we do labs. If the ACTH is super high, that means my pituitary gland is probably producing too much ACTH, right? If my TSH is too high, it's probably because my pituitary gland is producing too much of it. Now, is that a secondary or primary dysfunction, endocrine disorder? So it's secondary or primary? Or if you have too much TSH being produced by the pituitary, that's not the thyroid's fault, right? If it's a thyroid's fault, it's called a primary disease. So this is a secondary hyperthyroidism, right? If I have too much pituitary action. All right, so hypopit versus hyperpit. If they have hyperpituitarism, we have to go in through the nose, through the sphenoid bone, and take out the hypophysis. Not the hypothesis, but the hypophysis is our pituitary gland. So it's called a transsphenoidal hypophysectomy. So transsphenoidal hypophysectomy. Okay, so we take out the pituitary gland, and now we have to replace everything else, right? If they want to have kids, right? We have to replace their their sex hormones, right? If they want to have good thyroid function, we have to replace TSH afterwards. Okay, and patients can come in with hypopituitarism because they have a tumor, obviously, and we might have to take out the tumor the same way, through the nose, right? Or they came in because they weren't taking their medications at home. They weren't taking their thyroid medication or their steroid or their glucocorticoids. And they can come in with a adrenal crisis, and that's where we have to like assess the cortisol level, give them steroids to try to fix the underlying problem. Okay. So tumors, again, everything endocrine is usually tumor related. That's what's causing the problems, and it's going to cause too much of the problem or too little of that release of that hormone. Okay, and that is the endocrine system.